And greetings, everybody. Welcome to the Public Health PBRN virtual meeting for December. It looks like we're getting a pretty good crowd on board. So why don't we go ahead and get started? And I'm sure we'll have some other folks join along the way. Again, thanks everybody for being with us today. As we always do, our first segment of the meeting is our Research in Progress segment, brought to us today by the great state of Florida and our colleagues in the Florida PBRN. I think today we're going to be hearing about some early work on one of our DACS studies, the Public Health Delivery and Cost Studies that is underway in Florida, focused on STD costing work. And so we are excited to have Lori Bilello and Bill Livingood, both from the University of Florida College of Medicine in Jacksonville, to take us through their work in this effort. So with that, Lori and Bill, are you with us?
Yes, can you hear us?
Yep, we're here.
Just great. Well, thank you again for your willingness to do this today, and we'll turn it over to you.
Great. For those of you who I saw in Kentucky in September, some of the initial slides may be familiar to you, but we wanted to go ahead and go through some of the basic elements of our study for everybody else. So just a little background about the Florida PBRN. We were formed back in 2012. We were part of the second wave, 2010 I mean. And we have a wide group of folks participating, including the county health departments, our Florida Department of Health Central Office, and the Florida Public Health Institute, and some of the other university partners. The PBRN has been managed by one of the local county health departments here, actually in Duval County, and just recently moved to the University of Florida in 2013, just due to some management changes in that county. But we still have a lot of participation from Brad Lee, who I think is on the call, as well as some other folks who we work with closely, like Thomas Bryant from the health department before. So for this particular cost study, we have a research team, including Bill Livingood, who's going to be co-speaking with me today, Bonnie Sorensen, who I see is also on the line. She is the County Health Department Director for Volusia County and also had a long career in public health, both having positions in the state office in Florida and in California. Myself, of course, and then Jeff Harmon, who is a health economist out of University of Florida in Gainesville. Stacy Shiver and Phil Street, who are in the central office. Stacy Shiver is in the Bureau of STD and HIV, and Phil Street's sort of like their finance guru for the Florida Department of Health. We also have two county health department directors participating, Karen Chapman and Judy Hartner, and both of these counties that they are directors of are fairly small, so it's nice to have the rural perspective. And then Radley Rima from the Duval County Health Department. So our primary aim is to identify the unit costs of delivering public health services, especially we chose STD prevention and control, and to examine the effects of variations in the delivery system characteristics on cost. And we're looking at, a lot of different variables. One of the things that is I guess an issue in Florida is standardization, centralization of programs versus having some county home rule in how services are delivered. Also, we have centralization of IT and HR systems throughout the state. And we wanted to look at the economies of scale related to population size with each of our county health departments in our counties, and whether or not local tax and other revenue support affects county health services that are being delivered, especially in the STD arena. And finally, how responsive are we to local government, community governance when it comes to issues within our counties? So why did we pick STDs or STIs? We call them STDs in Florida, but I think the rest of the world calls them STIs. Essentially, we looked at the Florida Public Health Practice-Based Research Network did look at several different kinds of services such as HIV and maternal child health, and we ended up picking STD since we have a lot of data and it's a lot of mandatory data that's being collected for reporting and surveillance. But we really didn't know how much the cost varied from county to county, and we really wanted to look into that in more detail. We do have really strong financial and service data systems to support STD delivery. Especially, we have a homegrown system called PRISM, which I'll talk about a little bit more, that we use to sort of track the cases and the activities with the cases. And most importantly, Florida has a really high and increasing rate of STDs. So it's really a major public health issue. And one of the things we've been seeing in Florida is a lot of the funding for STDs has been going down and cases have been going up. And that's something that it's been probably going across the country as an issue. So our overall cost model, you can see, is very simple. It's looking at inputs, processes, and outputs. I think we're finding out that it's much more complicated than this due to the variation of procedures and resources by county. Most of the counties have dedicated disease intervention specialist staff that are assigned to STD services, but in some counties they may have other responsibilities and cross over into other services. And then some counties may have limited services due to staffing as well. So those are the kind of things we want to look at in part of our cost study. We have a lot of data sources available to us in Florida. One is the Financial Information Reporting System, or FIRS. This is literally looking at expenditure data per county, and it can go into by major funder, by major service category, and that's some of the things we're going to show you today. There's also another kind of system called Employee Activity Reporting System that looks at employee time allocation per cost center or activity, which we haven't delved into yet. That's next on our list. And finally, we have the Patient Reporting Investigation Surveillance Manager, or PRISM, which is really the case management system for our STD and HIV processes. And we have some very macro level data from PRISM, but we really need to go into the more detail as part of our cost analysis. So I'll let Bill talk about what we've been playing with right now for our big picture analysis, and we'll go into more detail with that.
Okay. So with our preliminary analysis, we actually got into a number of the research questions that we're looking at. We, because of the PRISM data and because of the EARS data and other data, because Florida has a very centralized HR system and a centralized IT system, we actually have some very good data. It can monitor workforce performance and in addition to the cost of services and so on. So we examined county-specific STD expenditures and disease rates, and the state of Florida had already been doing a lot of analysis on some of this, so it's readily available data. County-specific funding for STD services and all county health department funding, including local tax dollars. So we were looking at the revenue and expenditures related to STDs and how they affected the cost. We also looked at county demographic characteristics. So we've been looking at things like the rates of STDs, the size of the population density, and a number of different kinds of factors like that that can contribute to, they could potentially be variables that influence the cost of STDs. For instance, if you have a very low population density, then you might have to travel a lot for each case. That might increase the cost of services. So we're looking at a lot of variables like this. And we'll start by looking at some of the STD reported costs. This is actually some data abstracted from some state analysis that's already been done related to the cost per service, the cost per client, and the cost per visit. So there's already work being done in this. And we looked at this and we saw the state rate kind of an average rate across the state was $47.59 per service. It was $259 per client, and the cost per visit was $157.56. Now, what we see here with a lot of this other data is the variation, the range of services. So even though we have a very highly centralized state when it comes to an HR system and IT, we see huge variation, for instance, in this simple service of services related to STD. So the county median, the cost per service is fairly close to the state average, but we start to see the cost per client is quite a bit lower, and the cost per visit is quite a bit lower on a county median basis. Now, that includes a lot of smaller counties, for instance. So that could, if there's a larger number of small counties, for instance, that have lower cost per service, then you might see that as a factor that could drive the cost down. The lowest level of cost per service, though, we see an incredible range here. The lowest range there is 84 cents per service in one county, $1.81 per client, and $1.43 per visit. So, I mean, that's the very extreme low range, and the highest ranges then are quite a bit higher than the state averages, nowhere near in comparison to the lowest level, but still 3 times the rate of some of the other services. And then you look at, so we looked at the 20th and 80th percentile to kind of try to factor out the extreme variations, the outliers in effect, and there we see something that is a little bit more providing a more of a range, and that relates to both the all 3 of the cost per service, the cost per client, and the cost per visit. We've tended to include Duval in some of these statistics, largely because Duval is kind of a reference population. It's one of the it's not one of the largest, but it is one of the larger counties. It also has fairly high rates of STDs, and so and we're located here. So we tend to look at that, and you can see that Duval, it has one of the higher rates, but it's got a lower cost per service, per client, and per visit. And there's a number of factors that we're looking at related to that, and some of them we're not even going to be able to get into discuss today. So let's go to the next slide, and we include this because we'll show this a little bit later in our analysis. One of the things that provides a source of discretionary revenue for counties is the local tax support, the tax support that comes from the county. So with that tax support, frequently that's discretionary funding, and so if you have a major health problem such as STDs, you could actually redirect funds in that direction. And so here we see, again, not a highly centralized state in terms of tax revenue, at least not a universal kind of approach to it. The state rate of county tax per capita support for low-income people is $5.89 per person. That's on an annual basis. And the state and the per capita support for the total population is $1.94. If we look at the state median is a little bit higher. So in other words, the upper level state counties are the ones that provide more. Actually, there's more of those than the state average. So the median kind of shows that on average, the counties actually are providing more than the state average. And then if we look at the lowest levels, well, we have some counties that are collecting absolutely zero tax support, and the highest levels are very high comparatively, $49.98 per low-income person and $13 per person on the total population. And Duval County, there again, is on the lower end of those things, of those 2 per capita tax support. So again, fairly large variations among the counties. The counties, in effect, have a large, have basically discretion as to how much tax support they're going to provide. There is not a minimum level of county tax support that has to be provided by the local government. And so some of them provide nothing, and some of them are actually provide a great deal of support. And just to give you a quick overview of our STD rates and cost per reported case, here we see some, the map on the left is basically showing the red areas as the areas with the highest rates of STDs. And you see an awful lot of that in the northern part of the state. And a few, though, in the a few higher rates in the southern part, but most of the higher rate counties are located in the north. They included a lot of rural counties, but also some urban counties. They also include 2 counties that are not very large, but have very large university populations, and obviously that could change around the distribution. Now, when we look at the map on the other side, though, that's the expenditures per case, and when we look at that, we see a very different variation among the counties that doesn't really follow the rates for STDs per 100,000 people. So the amount that counties spend doesn't appear to be, from these maps, does not appear to be related to the actual cost. The actual amount of cases. So the cost, the expenditure per case doesn't seem to correlate very well. That's just with the map. Now we have some other analyses that we've done to illustrate some of these things. So I'll go back to Lori.
We also looked at some of the top 15 counties with the highest STD rate and looked at their expenditure per case, and it's really all over the map. As you can see, Leon and Alachua counties are the 2 highest, but there also are 2 major college towns with FSU and UF. But what's very interesting is Gadsden County is actually close to, right next to Leon County, but it's a fairly rural county, and it's also 50% African American, and it has one of the highest rates. And then Union, which is a very, very rural county, had some high rates. And you could see between Gadsden and Union the big disparity in cost, where Gadsden was the most expensive cost per case and Union was the least. So there's a huge variety of cost per case versus the STD rates, for at least for the top 15 counties. And there's a little bit more consistency as we go, into other counties. So we also looked at the STD rate in the population density by county, and this is population per square mile. And so you can see that the high STD rate counties are fairly rural. Leon a little bit bigger and Alachua bigger than the rural counties of Gadsden, Union, and Hamilton. Jackson is another really rural county. In the 10th, or I guess 11th, 12th, 13th, 14th, and 15th highest rates are all rural counties: Columbia, Madison, Taylor, Bradford, and Henry. So you can see how it's all over the map with population density as well. So we did a preliminary regression analysis on some of these variables that we already had information on, such as population density, STD rates, the percent of population below 200% poverty, percent non-white in each county, and the percent 24 and under in each county. And we also looked at the additional tax funding that the county government may be providing to the health departments. And we all looked at these different predictors on the outcome variable of the STD cost per case. And so our results really show that only 2 variables were found to be significant. Looking at a best subset selection method using R squared as our selection method. And so you could see that the STD rate and the healthcare tax per capita were the 2 variables that had some kind of significance to the cost per case. So for the STD rate, there's an inverse relationship. So as the rate increases, the cost per case decreases, even though the coefficient's pretty small. But that would make sense. As you have a higher rate, you'll have some economies of scale with that. But what's even more interesting is the healthcare tax per capita effect. And you can see how as the per capita dollars increase per county, you see an increase in the cost per case as well. So the counties are using their discretionary tax dollars to help supplement providing STD services here. If you have anything else you want to add, but
Yeah, just, I mean, there's kind of, you would think that with an STD higher rate, you might be getting into some kind of economies of scale, that the higher the rate, the more efficient you'd be able to do, because you'd have more staff and they'd be efficient and be able to have dedicated skills and resources to different types of issues and so on, and you might expect some efficiency there. Apparently, we're not seeing that with this particular, with STD rates. It may be that there is more of a diseconomy of scales, in the sense that maybe we have STD rates that are high enough to have efficiency throughout the state, and what happens is when you get very high rates, you may not get a scalable benefit, and in fact it may actually start to overwhelm the systems. So that might be one plausible explanation for that. So these are some of the things that we want to look at much more thoroughly. Let's go on to the next slide and look at some of the things that we obviously came across. One is that we had very high STD rates in rural Florida counties throughout, so that's kind of a major issue. There were a couple urban areas that also have very high rates, but the problems seem to be very common throughout the rural parts. Even some of the southern areas were very rural. There's wide variability in the cost for STD services across the state. I mean, that, again, here you might have thought that because Florida is characterized as a very highly centralized state, that you wouldn't have that kind of variability, but it's pretty amazing, quite frankly, how wide the variability is. The wide variability in discretionary or local tax funding for county health departments seems to be the most predictive factor for the variation. I guess, looking at that, it's very plausible in the sense that the more money you have, the more you can put into something like that. So, and the implications for, there are major implications for implementing micro cost studies. Just one other comment related to discretionary or local tax funding. That seems to be a major factor, and we looked at quite a few, actually, other things, such as the population density and a large number of other variables that might have potentially impacted this. So it wasn't just that those two things came out. We actually did some bivariate correlational studies, and we found one or two other things, but when we put them all in, it was what Laurie had just gone over, which were just the two factors. So we do have some very important findings, but let's go to the next slide. There are some unanswered questions here. One of the things is that we do need to refine our secondary analysis to provide additional clarification and consistency of measures used to calculate the services, the cases, and the visits. So we're, I mean, some of our analyses where we weren't able to have the exact same year for all the comparisons, and like with the service, we're using kind of a generic service, probably isolating it to some specific services and doing some comparisons around specific services might help to provide some greater clarity about what it is that we're finding. We also need to, in the secondary analysis, to start to identify a purposeful sample of county health departments reflecting these major variations for additional study. And I'll come back to that a little bit later. We are going to be surveying all the county health departments to try to start to clarify some of these variations in service delivery. In some cases, some of this can be a reporting issue. I'm not sure how many of you have seen I've read the book about The Wisdom of Whores, but it's a book about epidemiological reporting and essentially how we tend to try to put round pegs into a few square holes. And the result is that sometimes just the data collection process can result in some variation and lack of, all kinds of anomalies that aren't explainable. So one of the things is we want to be surveying the county health departments to get clarity about where they are with these variations in service. They even clarify when they're recording these data, are they all thinking along the same lines? Are the people that are entering this data all reporting the same way? We want to try to verify or fill in some of the gaps that we identify with the secondary data analysis. And then we also want to, with this, to clarify even more what the purposeful sample of county health departments is. Then we're going to get into more in-depth interviewing of key informants of a purposeful sample to discuss and clarify the findings. So let's go to the next slide, which is kind of a variation in our approach to cost analysis. Some of the efforts in regard to the STD cost analysis start with a micro cost analysis with a small sample based on a convenience or some kind of pre-identified characteristics, and then they try to generalize to the larger body. We're kind of starting with a macro analysis of larger group and drilling down to explain the differences. So it's kind of a different approach. To do this, though, we have to be dependent on a valid and well-established data reporting systems, which Florida happens to have. So that's kind of where we are with our analysis. We're very happy to learn that as we projected, that Florida had a great deal of data that enabled us to do some very informative analysis of the current situation, and we're looking forward to doing a more deeper analysis. Our project also, we're going to be working with Georgia potentially. Georgia is still in the process of obtaining some funding for us to do some comparison across states. Georgia has a relatively large population and a very decentralized system, so we're looking to see if there might be some insights that can be gained from that comparison. And that's pretty much our slide presentation, and we're happy to answer any questions that you might have.
And I see that there is quite a few questions in the chat room, and thankfully Bonnie's been addressing those, so we appreciate that, Bonnie, especially since a lot of them are very specific about how the health departments provide the services in these for STD services. So really what we've showed you today is just a very, very high level, macro level analysis, just to try to get our feet wet before we dig into the full cost study. But I think it shows us that we have a lot to learn from the different counties in Florida. Not one county is similar to the other, and it's going to be hard to really look at costs by some kind of average throughout the state. So we'll see how this works as we get more into it. So we're looking at your chat questions right now.
And again, we welcome others who've got questions to use that chat box. It's a good way to get questions queued up here.
You can also move slide it up and down so that you can read all the questions from the beginning.
So should we read them out loud for everybody, or do you think everybody can read the chat questions?
I think it might be good in case there are people who are just on the line but are not on the web.
Okay, one of the first questions is Union County, which is the county with the lowest cost, adjacent to Valdosta, Georgia, and it's really between Jacksonville and Gainesville. It's probably a few counties away, and it's not a college town. It's 2 counties away from a college town. It's very, very rural. So another question is, does Florida have or promote expedited partner therapy? And if so, is it statewide or by county? And Bonnie said it's recommended by state, but pretty much depends on individual counties, especially the physicians and nurse practitioners in the county. And I know even in Duval County, they had done it at one time, and now they don't do it due to some liability issues. Another two questions is, do costs vary significantly by type of STD, chlamydia versus syphilis versus GC? We don't know yet. We haven't drilled down that deep yet to know. And do STD types vary significantly by geography? Yes, they do. We do have different kinds of outbreaks and issues. Bonnie said that syphilis is more prominent in South Florida, where MSM population is highest. Otherwise, it's chlamydia and gonorrhea.
Yeah, I mean, overall, most of the data and we have a lot of data showing what the rates are for STD, for chlamydia and gonorrhea, and it's far, far beyond what the syphilis rates are. Although, as Bonnie pointed out, the syphilis is more dominant in the southern part, but it's still nowhere near the rates, I don't think, of chlamydia and gonorrhea.
And Bill, this is Paul Irwin. One of the reasons I asked this question is that I know in some of the larger counties in Tennessee, they have so much chlamydia that they don't even really spend any time with it. I mean, they don't do contact investigation or anything like that. And so the cost for that are very different compared to, say, a rural county which sees only chlamydia. And so knowing the cost by STD type and then knowing where STDs occur in terms of geographical dispersion, I think would be important factors in trying to understand this relationship between cost and rates.
We didn't see that when we I'm just overviewing the data, but we separate just we didn't analyze the data for that. We should, but it didn't strike us as something that where we saw that kind of variation. We saw both chlamydia and gonorrhea both being pretty high rates across the board. We did, by the way, do some analysis trying to look at, was there a relationship between the cost to a couple of outcomes, and in particular we looked at the 7-day treatment rate. In other words, percentage of people that were treated within 7 days of the time that the STD was identified, and we did not find, with all of the various factors, we couldn't find any predictive factors in regard to that either. I mean, we saw some pretty big variations, by the way, in some of the counties being pretty low in the number of people that they saw within 7 days. Once we got to 14 days and 30 days, the numbers started to all get pretty consistent. And so it wasn't, you wouldn't expect much to be learned from a statistical analysis when you get pretty much a homogeneous response. But at the 7-day level, it was a very heterogeneous response rate, treatment level. So, we're still looking at a number of these issues, and but getting down into the details that you suggest related to specific diseases, or one of the things is that we want to look at is specific services, because the type of service may have a lot to do with the variation also.
And the different counties also use a priority grid of which types of cases that they will follow up with interviews, and it's based on age and type of disease and those kind of things. And we really need to delve into that priority tiered grid a little bit more to see how each county is using that grid.
Another variable that we found also that we haven't really started to analyze in too much detail yet is there's also a mix of private and public sector follow-up for STDs. So some, such as Duval County, are pretty heavily reliant on the private sector, and many of the other counties are almost totally dependent on the public sector for funding. So there's obviously a large number of variables that can influence this, and obviously getting into the details of that are going to help to inform this much more. But I think one of the overall messages is, we've heard the expression many times, if you've seen one county health department, you've seen one county health department. That seems to be true even in a highly centralized, so-called highly centralized state like Florida.
Guys, this is Pat Checo. I have a funding question, which is very basic, and maybe I missed it. Is there a defined amount of money that is given to each county by the state specifically for STD, or is it more like our state where you get $1 or $2 per person for everything you do, and they have to use their discretion as to how they spend it? And the second piece is...
We have about eight different sources of funding that are monitored related to both providing the STD, specific funding of STD services versus the more generic. And so we were analyzing the specific amounts of funding dedicated or allocated to STD follow-up. But keeping in mind that that can be variable also. If you're trying to get money from the local tax authority, they might tell you to justify what you're going to spend the money on, and therefore then you might have an allocation for STD. Another county might not have to do that, and the result is that they could be putting the money into STD, but it might not show up as an allocated. We have a number of these. Let me just finish. We have a number of factors that related to that. There is specific funding coming from the state. There's federal grants coming that are for STDs. There are also Medicaid funding that come for this, and then there's GR funding from the state. So there's a number of different sources of funding, and the state attempts to monitor that, but again, it's dependent on the county identifying it, and not all the counties would necessarily identify the allocation for STDs.
So in the final analysis, even though you may be calling it a local allocation, until you really start delving into it, it may be funds that they receive from other sources as well besides the state.
No, for the local allocation, it's very specifically the county commission or taxing district funding. So we do know that per county.
Okay, thank you.
What's supporting the service could come from different services. The funding for the employee, they could be supported by different levels of funding.
And that's county money that is generic, not necessarily for STDs. They may have a county funding for that health department that's a little bit more generic, like primary care services or prevention services.
Mm-hmm. Thank you.
Great questions and great analysis here. I might jump in just with one comment as well. I think the obviously this is very much a work in progress. You guys have got a lot of exciting analyses still teed up to work through. But in thinking through that analysis, or that result you showed about the relationship between local tax funding and the cost per service, you guys have probably already thought a lot about this, but there's lots of ways of interpreting that kind of finding. The crass way is does that imply that when there's more money available, public health agencies are able to be less efficient in delivering services? On the other hand, I think the more plausible explanation is that those places that are spending more local dollars are probably doing a lot more there. That the mix of services and activities are probably more intensive, and that's why they're spending more money. And so it's the causality might run in the opposite direction. But and I know that's likely that you've got additional analyses to get to look to kind of peel back those layers of the onion and to look more specifically at the practice patterns and the mix of services, specific services that perhaps explain this variation. But any further comments on that particular relationship between funding source and cost per service?
I think that's very true because some counties don't do any kind of outreach or testing, community testing, and other counties do. And so some of the county funding may be used to do those kind of services.
Yeah, I think that's where also getting into instead of treating it as a generic service, actually getting into the specific services that are provided and doing not only a cost for those specific services, but looking at potentially then the amount of services. It could be that, as Lori pointed out, that more extensive follow-up might involve more money, and you may not even be able to do that. You may not even be able to think about it if you have a very low per capita funding and essentially no discretionary funding. So those types of things. But I think it's very plausible also that if you have more money, you might be able to be a little bit more inefficient too. So we're kind of, we were kind of surprised at this gross level that more things didn't kind of jump out to explain some of the differences. And so obviously going down into the details more about the specific services and how those specific services are supported and funded. And so you're really getting into that unit cost type of thing. We really need to narrow down the unit from a general service to specific services such as outreach or, contact, partner contact or other kinds of things.
Yeah. It's a classic problem of, funding sources tend to be endogenous and they're driven by other factors, and so that'll be important to tease out in your more nuanced and more focused analyses. Excellent work. Any other last questions for our Florida PBRN team? Well, stay tuned. Hopefully, we've whetted your appetite about some of the great work that is occurring through these DACS studies. And again, thanks to Lori and Bill for being our first DACS research team to share with us some of your preliminary work. This is really impressive. I'm really impressed with what you all have been able to accomplish already through this project, and very excited to learn about what your further analyses show as you move forward with this project. So thank you so much, Lori and Bill, and we'll stay tuned to hear more of the evidence that flows from your project as you move forward.
Great, thank you so much.
And with that, we can transition over to the more mundane section of our agenda for today. Some of our administrative items on deck for today. Let me start by just some other general updates about research that's underway through our PBRN program. As we've talked about before, and you've heard some of the progress before related to our improved set of research projects, the multi-network practice and outcome variation studies. Those projects in general are winding down data collection and ramping up analysis and reporting activities that are occurring through those networks. We're hoping to see a lot more analysis happen with those data over the next couple of months. We've been working at the coordinating center to build the multi-network analytic file from those measures and have that nearly complete. Still waiting on a few items from some of our participating networks, but nearly have a complete set of measures of volume, intensity, quality of public health delivery in the measurement domains, and that then will allow us to move forward into some additional data linkage and some more intricate analyses to tease out causes and consequences of geographic variation in public health delivery in the service domains that are represented in the improved measures. So we're excited about those projects moving forward, and we know several of our networks are also pushing ahead with their individual network analyses as well. And so I think you'll begin to see, I know you'll begin to see some additional results flowing out of the improved projects in the coming months. We already have I know some early publications in the queue from some of the improved projects. So great to see that happening. And again, congratulations to our 7 improved participating networks that are part of the improved effort. I'll also say, as we're working with the foundation in discussions around subsequent research funding opportunities for the networks, we're optimistic that there will be some opportunities some funding opportunities that will allow networks to do additional work around the improved measures and additional work looking at, again, causes and consequences of variation in the delivery of public health services, particularly those that are represented with the improved measures. So we'll keep you posted as those ideas and opportunities develop at the foundation. We also, as we just heard, we have our DACS studies that are underway. 11 of our PBRNs have DACS projects that are getting moving further along into implementation. Again, some of those studies are 12-month, shorter-term 12-month projects, and some of the projects are longer-term 18-month projects. But I think the networks overall, the DACS projects overall, are making some good progress. We've hosted at least one round so far of conversations that allow the studies to share research protocols so that we can work toward standardizing some of the analytic approaches and some of the measurement approaches that are being used with the DACS cost study projects, and we'll have another round of that next month, just after the holidays, another round of protocol exchange and methodology sharing and standardization, so that hopefully as these projects move forward, we'll have some opportunities for drawing comparisons across these 11 studies, in addition to the important work that will come out of these studies on an individual study-by-study basis. So that's those projects, I think, in general are moving along quite nicely. And again, as we saw from Florida today, some of our projects are already producing some interesting findings as they move ahead. We also have been hard at work on a related effort that we've been leading through the coordinating center, again with RWJ support, around developing a methodology for estimating the costs of what are being called now foundational public health capabilities. This was a work that came originally out of one of the recommendations from that 2012 Institute of Medicine report on public health financing, specifically the recommendation to identify the components and then the cost of a minimum package of public health services. And in that minimum package includes a set of basic public health programs, as well as cross-cutting public health infrastructure and capabilities. There's been a project underway for about 8 months now, a expert panel process convened by the foundation and in collaboration with CDC and some other stakeholders to identify and articulate these cross-cutting public health capabilities that are recommended to be available in every community, in every public health setting. And that work group, again, has been underway since the spring to define those cross-cutting public health capabilities. And then we convened a second expert panel beginning just earlier this fall, beginning in September, a group of largely methodological experts to develop a methodology for estimating the cost requirements associated with those with establishing those cross-cutting public health capabilities, both at state and local level. So we've been meeting monthly and having periodic convenings in Washington to make progress on this this cost estimation strategy. I think we're getting close to finalizing the cost estimation methodology recommendation, and over the next month, and then likely we'll be working with the foundation to specify a process for actually implementing that cost estimation strategy. And so that work has been progressing, and again, it's been certainly informed to a large extent by some of the cost estimation work that has already occurred within several of our PBRNs, particularly the great work that's happened in Ohio and in Washington, and also in Colorado, in terms of looking at cost and resource requirements around foundational public health capabilities. So several of our networks who have done some of this early pioneering work around cost estimation for foundational public health capabilities, that work has already begun to inform national dialogue and now national recommendations around these activities. So so that's you're already, those of you who have been working in this arena, you're already having an impact on the national conversation there. We'll keep you posted as that national cost estimation work continues to develop. Our target is to have again a set of recommendations around methodology to be finalized sometime early 2014, and once that's finalized and can be made public, we'll make sure to share it broadly with our PBRN colleagues, and then also hopefully that set of recommendations around methodology will then lead to an implementation period where we'll actually have some national cost estimation studies happening in conjunction with that, with those methodological recommendations. So we just wanted to keep you apprised that project continues to move ahead with a lot of speed behind it, because there's obviously a lot of interest nationally in understanding these issues of cost requirements on a national level. So a few updates on the ongoing research projects through the PBRN program, and feel free to use the chat box if you've got a question or on any of that. And if not, we can move on to our next item on the agenda, which relates to dissemination opportunities. Just to make sure that these are all on your radar screens. Again, we've got a variety of projects underway through the PBRNs now, and many are continuing to bear fruit in terms of findings and papers and briefs and other products. A reminder that Frontiers is always a great vehicle for getting out early findings. We've been doing some work this fall to kind of some continuous improvement work to continue to streamline the publication process at Frontiers, and I think that's been going well. We are also we can give you a little bit of some early news. We haven't announced this publicly yet, but we will officially announce this new development right after the holidays in January. But we have developed a new relationship, a new publication partner with regard to Frontiers, and that is the American Journal of Public Health, AJPM. We have developed a new publication relationship between Frontiers and AJPH that will function in many ways like our prior agreement with the American Journal of Preventive Medicine, and that is that AJPH beginning in 2014, beginning in January. AJPH will now be publishing highlights from papers that appear in Frontiers. And those papers will also, to the extent that that Frontiers manuscripts eventually become full-blown, larger-scale scientific manuscripts, those manuscripts that are submitted to AJPH now will receive kind of expedited processing and consideration through the peer review process at AJPH. So we're really excited about that. Again, you'll see a formal announcements on this this new relationship next month. Our partnership with AJPM has been a great one. AJPM really helped us birth this new journal and was very helpful in helping us launch and work out production details. The new relationship with AJPH, I think, is just going to help us reach an even larger audience. Obviously, AJPH is probably hands down the single most read peer-reviewed journal in the public health world, in part because of its affiliation with APHA and the fact that those 40,000 or so APHA members typically automatically get their journal subscription as a benefit of their APHA membership, and so we think we'll obviously be able to reach an even larger audience with the affiliation with AJPH and the joint publication relationship there. So we're not abandoning AJPM. We continue to have a great relationship with AJPM, and certainly encourage all of our colleagues working in the PHSSR field to continue to use AJPM as a platform for publishing your work. But just know now that we've got another partner who is eager to support publication of peer-reviewed findings in the field. And so please bear that in mind as you all are thinking through publication strategies with some of your PBRN research. Know that we've got this new relationship with AJPH that will be coming online formally and officially in January. So as you're thinking about papers and manuscripts, keep that in mind. One other issue more specifically on that regard is that we're going to be doing another special issue of a journal, special journal issue devoted to advances in public health services and systems research. This special issue we're going to be doing with our new partners at AJPH, and so again, as you have findings that are coming together through some of your PBRN research projects and are developing manuscripts, consider submitting a paper from your PBRN research to this special issue of AJPH that will be devoted to advances in public health services and systems research. You should see, for those of you who are regular readers of AJPH, you should see an announcement of this call for papers as part of the special issue on PHSSR appearing in the journal beginning in the January issue. My expectation is that'll appear in the January issue for the first time. I believe we made the deadline to get that call for papers in. The manuscripts themselves will be due in the middle of March. I can't tell you the exact date, but maybe the 10th or the 15th of March 2014. If you want to have your paper considered for that special issue. So we wanted to give you the early heads up on this. Our PBRN colleagues, again, you'll see formal announcements about the special issue in the American Journal of Public Health starting next month, and it'll be in our newsletter and on the website and other places as well. But you heard it here first as a benefit of being on our monthly virtual meeting this month. Other dissemination opportunities. As you see here on the slide, we're we're deep into abstract submission season for a lot of our big national public health meetings, and so we just wanted to make sure these were all on your radar. The first deadline coming up is the deadline for abstract submissions for the NACCHO annual meeting, a very important meeting for all of us in public health. That deadline was extended from earlier in the month. It's now Christmas Eve, December 23rd, I think, at midnight is now the new deadline for the submitting sharing session proposals for the NACCHO annual meeting. So please consider, if you've got research that's ready to present from your PBRN work, please consider putting together a sharing session abstract for that meeting. It's the single best place, again, to reach a local, a national meeting to reach a local public health practice and a local public health administration audience. And so keep that in mind. Typically, the sharing session proposal at NACCHO, typically these sessions involve panels, essentially, with typically multiple speakers, and so keep that in mind. That deadline's coming up quick. Right after the holidays, we've got the deadline for abstracts for the Keeneland Conference. This is the conference that we have the pleasure of hosting here in Lexington. And so the abstracts for the main Keeneland Conference are due right after the holidays on January 7th. We always love to see a strong representation of PBRN research at that meeting, and so please consider pulling together an abstract of some of your PBRN's work for that conference as well. As we always do, we will be having a PBRN grantee meeting in conjunction with the Keeneland Conference. Typically the day before the Keeneland meeting, Monday before, we'll be getting together as a PBRN program. And so hopefully you're making plans to be with us as part of that. And so while you're there, you might as well present some of your great research at the meeting as well. So keep January 7th on your radar. And then one of our other big research meetings of the year, Academy Health, the abstracts are due for the Academy Health research meeting on about a week later on January 16th. Public health has been one of the core theme areas of the Academy Health research meeting for a decade now, and we've continued to have great success with growing the volume and quality of studies that are presented in the public health track at the Academy Health ARM annual research meeting. And so help us to continue that tradition by submitting some of your best research to that meeting. It is a research-oriented meeting, predominated by health services researchers and health policy researchers, and we're obviously want to see public health topics, issues around public health organization and financing and delivery well represented at that meeting. And so consider that option as well. There's also, as many of you know, there's a let me pause. A question on that?
Yeah, this is Anna. I just wanted to jump in and remind folks, I believe Kate was on last month, but I wanted to remind folks that there will be an opportunity again this year to apply for PBRN-specific scholarships to attend the ARM and the IG, and we're expecting to get a mailing on that out. If not by Christmas Eve, then right after the start of the new year. We're working with Academy Health to get all of the I's dotted and T's crossed for that. So if you're interested in attending Academy Health, if you're interested in submitting, be sure to put that on your radar so that when you get that, you'll be ready to send in your application. Thanks.
That's great. Thanks, Anna. Do we know anything about the deadline for that?
I believe it's going to be the last day of January, so it's going to be a pretty quick turnaround, but it's not an extensive application.
Yeah, great. Thanks for that reminder. That's a great opportunity. We did that for the first time last year, and people are winners of that opportunity seem to get a lot out of it. You remember a few months ago we had kind of a debriefing session from some of our scholarship winners, and so that's a great opportunity. And again, the interest group, the PHSR interest group meeting that happens in conjunction with Academy Health, has a separate abstract deadline, typically about a month later. The abstracts for the interest group meeting, which happens basically the day and a half following the main Academy Health meeting, those abstracts will be due on February 14th. And so keep that in mind as well. Typically, those are panel abstracts as well. The Academy Health meeting, I think, this year is going to be in San Diego in June, so it'll be a great session. And we hope to see a strong contingent of our West Coast PBRNs in particular, since we'll be in your neck of the woods, California and Washington, perhaps. And then APHA is also now accepting abstracts as well. Those deadlines are in February, staggered deadlines based on what section in particular you're interested in. On that front, I can tell you I've been in conversations with the Health Administration section, which has been one of the Academy Health, one of the APHA sections that has historically been especially interested in PHSSR work, and we are going to be working with that section to develop some specific sessions related to PHSSR, and so we'll share with you more information on that as we start to solidify those plans. But obviously, APHA is another very important meeting, national public health meeting for us, and so make sure you've got those deadlines on your radar as well. And yes, there's an announcement for our AJPH special issue. That's what I had talked about earlier. It is March 10. If you're thinking about a paper to submit for the special issue, we will be producing in the American Journal of Public Health related to advances in PHSSR. Think about having your manuscript ready to submit by March 10. We'll have more information coming on that next month. For funding opportunities, we've got a few that are listed here, and important to keep in mind. First of all, as we talked about before, we do still have quick strike research funding opportunities available. We got a robust response, I think, last month. A number of quick strike applications came in, so those are going through the review process, and you'll be hearing from us very shortly if you submitted a quick strike application in this second cycle. But continue to be thinking about time-sensitive research topics and interests that may be bubbling up within your network that would be appropriate for a quick strike application.
And as a reminder there, I'll just jump in real quickly. I know that folks had, we had the deadline November the 30th, I think, and we had more than 3 times the number of submissions we did the first session. So I'm gonna give you a heads up. The next deadline is February 28th. So if you're considering submitting one, you might want to go ahead and get that in early. Just a suggestion. Thanks.
Great, thanks, Anna. So keep that on your radar. We also will be releasing very shortly just a notice of an intention to fund another round of a research program that was formerly known as the Junior Investigator Awards in PHSSR. We're now that's now that program. We expect that program will be refunded by the foundation, and funds will be available for a 2014 round of applications. And so we'll be issuing shortly a notice of intent to issue a call for applications under that program. The new name for that program is the Predoctoral and Postdoctoral Research Awards in PHSSR. We've moved away from the slightly pejorative junior investigator terminology there. This is a funding opportunity, obviously, that is designed for early career investigators in the field of PHSSR, either people who are reaching the dissertation stage and are looking for funding to support their dissertation research in PHSSR, or people who have recently completed that phase and are in the early years of their postdoctoral research career and are looking for research support to stimulate and further their progression as a postdoctoral researcher. So again, we expect the foundation will be releasing a call for applications for another round of that program in 2014. Keep an eye out for that official notice of intent. It'll be in our newsletter. We'll have it on the website and other places. But this early notice is just to make people aware of this expected funding opportunity, so that if you know of early career investigators who are again at the dissertation phase or in the postdoctoral phase, they can begin to think about this opportunity and start to put together research plans for that. We expect that the call for applications will be released in April, and the applications we expect, again, all conditional on availability of funding from the foundation. We expect the applications would be due in June, if I'm remembering correctly. But the details on that will be listed in the notice of intent that will, again, you can see it in our newsletter, our next edition of the newsletter, and on the website. But keep an eye out for that if you know of people at that career stage. Be wonderful if you find people at this career stage who want to work with your PBRN on a dissertation or a postdoctoral research project that could be embedded within your PBRN. In fact, we expect to be soliciting PBRN-related studies through this funding announcement as well. In terms of RWJS funding, a couple of other opportunities that have come out recently. There's the HICFO funding initiative that's listed here, that changes in healthcare financing and organization, which is accepts application on a rolling basis, typically for studies that are related to healthcare delivery and financing. But obviously there's a lot of interesting work happening now that looking at the boundaries of healthcare and public health delivery. So and we know that several networks are pursuing lines of investigation in this area, and so keep just to remember the RWJ initiative in that regard. There's also another funding opportunity that has recently been announced through another program at RWJ called New Connections, and the next round of funding for the New Connections program was announced a couple of weeks ago. This is a program that's explicitly designed to engage people from backgrounds that are underrepresented in the health research arena, to provide them with funding opportunities and also career development and networking opportunities. So the next round of funding for the New Connections program has been announced. I think the applications are due sometime in January, if I remember correctly, and Lizeth has just posted the link to the New Connections site there on the chat box. This is a great program. I've had several mentees in my career go through the New Connections program, and it is a great program, again, particularly for designed specifically for people from backgrounds that are underrepresented in the health research field. And we've also had several New Connections grantees that have done work through PBRNs in the past, and so again, we want to make sure that's on your radar to think about those opportunities. What else here? CDC. There's been there was a recent funding announcement from CDC designed to support policy analysis and research, including economic evaluation studies in public health. We'll make sure to have that application, that funding opportunity featured in the newsletter as well, and that again may be of interest to some of our PBRNs who are doing policy-oriented or now economically oriented research, such as those underway through our DACS projects. And so that's one opportunity that has opened up in the last couple of weeks we wanted to call your attention to. And then finally, ARC. ARC is always a great funding source for studies of health systems and health services research. One opportunity, an R21 opportunity that was released in the last 2 weeks relates to studies looking at methods of deliberation in engaging stakeholders in deliberation around health issues and alternatives. And so that R21 call might be again of special interest to PBRNs, given the role that public health systems can and in some cases are playing around community engagement in public deliberation issues around health and health care. The movement and additional energy around community health assessment and community health improvement planning processes, for example, as mechanisms of community engagement. And so that call might be of interest to folks, the new R21 call from ARC. So as usual, these and other funding opportunities that we that come across our desk, we'll make sure to feature in the newsletter, so the monthly newsletter. So again, stay tuned for that. Anything else? Let's see. Questions. Pat asks about the public health law research call for proposals. PHLR. I'm trying to think. I know that PHLR has they have an explicit connection to the New Connections RWJ funding mechanism. There's an interest specifically in New Connections applicants who have an interest in public health law research proposals. I'm trying to think if I've seen the next round of PHLR. If there is another PHLR call, we'll definitely make sure that it's in our newsletter. Yeah, I haven't seen it yet. Patrick's saying that he thinks that there's another call coming, and it may be the case. I do know that the PHLR annual meeting is coming up next month, and so there perhaps will be a release on or around their annual meeting date.
I think the calls are usually the due dates are in the summer for those usually, aren't they? June, July-ish.
That's correct. The last one for 2013 was in July.
So stay tuned for that. But there is an explicit PHLR call within the New Connections program. So for those applicants who are interested in New Connections who've got a public health law interest, there's an explicit interest in that. Okay. Other things to announce. We've got about 10 minutes left. We're pleased to see the HAPM theme issue on public health PBRN research is out. It's part of the December issue of HAPM. It's been out online for a couple of weeks already, and we were already seeing a lot of hits, a lot of interest and enthusiasm around these papers. So again, thanks to our PBRN networks that contributed papers to this this issue. And if you haven't seen this work, you need to check it out and go see the great papers that are here. We had a nice overview piece that we developed with some of our colleagues in the PRC program, talking about some of the points of intersection between PBRNs and prevention research centers, and then a nice series of 5 papers featuring some of the great work from our PBRNs. And we also did a kind of an overview paper using some of the network analysis data that we collected in past rounds of the PBRN program, looking at patterns of interaction within PBRNs and patterns of engagement in research implementation activities. So strongly recommended reading for those of you who haven't had a chance yet to dig into some of these papers. And we also, let's see, thank you. Another important issue didn't make the slide here, but another great issue that is available now is a special issue on accreditation that is found in the most recent issue of the Journal of Public Health Management in Practice. I think it's officially the January-February issue, but it's available now online for those of you who are regular readers of JPHMP. The entire issue devoted to accreditation, supported by colleagues at CDC and with strong involvement from some of our colleagues at RWJ. There's some great research studies related to accreditation and some very interesting case studies of public health settings that have undergone the accreditation process, their experience and strategies with preparing for accreditation. We've even got a kind of a commentary in there laying out some of the research issues that remain to be addressed and the research needs and opportunities related to accreditation in public health. So we also recommend you taking a look at that. And we're likely to see a continued push and a continued call for research that can inform the accreditation activities in the public health sector going forward. So put that on your Christmas reading list as well if you haven't seen that already. And congrats, I know a number of our PBRN stakeholders were involved in those papers. A great paper, for example, from the Colorado PBRN on some of their PHLR research related to accreditation and legal requirements. So lots of dissemination stuff happening these days. Other discussion items. This is, just as we're wrapping up here, we are entering we are in now the last year of our authorization for the PBRN program and the PHSSR Coordinating Center. And so we are entering a period of discussions and conversations with the foundation about reauthorization, new authorization, and what that may entail. And so obviously, very important discussions, and this is happening as the RWJ, as the foundation's larger strategic planning process is wrapping up, and now we're ramping up around conversations about renewal and reauthorization of both the PBRN program and the larger PHSSR portfolio and the work that the coordinating center here engages in related to the larger field of PHSSR. What you can help us do in helping us to help the foundation think through these issues is to make sure that we've got the latest up information about your network and what it's producing and doing. In particular, two critical items, just to remind folks of, as a PBRN, having an up-to-date membership directory, an up-to-date update inventory of the people and organizations that are part of your PBRN. That's very important, and that information will be very important for us to be able to communicate to the foundation, for us to be able to accurately portray the types of organizations, how many and what types of organizations are, and how many people are involved in our PBRN. So having that membership directory, that roster of PBRN members for your network, very important. And so if you're able to update that your membership roster and provide it to us, that will be very, very helpful. The second is essentially your network's bibliography, your inventory of the research projects that your network has received, and the inventory of projects you've conducted, and the list of research projects that your network has completed over its history. Having that bibliography, very, very important for us to be able to document the great work that you all have done, to be able to communicate the volume and the breadth of research activities you've undertaken, and also the volume and the breadth and types of research products that your network has been able to produce. Papers, publications, presentations, testimony, whatever it is. So just a reminder to if you could help us help you, help us continue to grow this this program by keeping those two elements of your network's curriculum vitae up to date, your membership roster and your bibliography of projects and products. If we can obtain those from you, that helps us fully and completely communicate to the foundation as well as to other stakeholders the great work that you all are doing. And so we wanted to make sure that that was on your radar.
Glenn,
so
this is Anna.
Yeah.
If I could just add one wrinkle to that. Earlier this month, we did send folks an email asking specifically for that information. And we also mentioned that if you have had an opportunity to spin out any additional funding opportunities as a result of some of the studies that maybe began as a quick strike or began as a race or a RIA, to please let us know. Sometimes we all get very busy writing our proposals and we forget to tell folks that we've spun into a new area of study as a result. So if you could just notify us of any of those opportunities that have come your way and that you've been able to capitalize, we would appreciate it. Thanks.
Yeah, absolutely. I think that's a critical part of your the bibliography you should be maintaining on your network. Funded projects, whether that's from the foundation or especially from other sources, because the foundation loves to see success in that regard. Projects and products, make sure that you're keeping up to date on that, documenting that. That's the CV for your network, and obviously that information is important to communicate to our funder as well as to other funders that we hope to entice into the circle of PBRN research and PHSR research. So thanks in advance for your efforts to help us keep tabs on where you are with your network activities. Lastly, last minute here, this is our schedule laid out for our research in progress presentations for 2014. One of the most popular, obviously, elements of this monthly call. And so, again, if you'll make note of this, if any of these dates don't look good for you, you're welcome to exchange out with another network. Just let us know, of any changes in the schedule, and we can make a note of that in the upcoming 2014 presentation schedule. And again, thanks in advance for your efforts to do this. Obviously, every month these presentations are a very valuable opportunity to get a glimpse into what's the research findings that are coming out of PBRN activities. And so we want to make sure we're able to continue these activities strongly into 2014. It looks like our next meeting will be January 16th, so make sure that's on your radar for after the holidays. And I think that's it. Let me pause and see if there are any last-minute questions.
Glenn, this is Jeff Cohen from Connecticut.
Hey, Jeff.
I had a question about the Keeneland Conference and grantee meeting.
Sure.
So I'm assuming that each PBRN will be making a presentation at the grantee meeting. And if that's true, is the abstract submission intended to be for a separate paper, or do you envision that some people might be presenting the same paper in both, or what's your thinking about that?
Yeah, good question. Typically what we've done with the grantee meeting has been a lot more interactive, and so we will certainly have discussions being led by PBRN stakeholders as part of the grantee meeting, but we typically haven't had formal kind of research presentation sessions at the grantee meeting. The research presentations are really held for the main part of the research part of the Keeneland conference, and so So you don't need to submit an abstract specifically for the grantee meeting. Everybody's invited, and we'll be rolling out more information about the agenda for the grantee meeting early in 2014. But you don't need to submit an abstract for that. The abstracts are for research presentations at the main Keeneland conference component of the meeting.
you.
Good question. Anna, anything more on that?
No, that's good. Thank you.
I would just add that we do, for the first time, have an external scientific steering committee for the Keeneland Conference this year. We do have some PBRN representation on that committee, and they've been doing a great job. So there might be some changes to the number of presentations accepted, the size of the poster, the poster session, those kinds of things, and we're really excited to share all of that with you. But get your abstracts in, and we're looking forward to sending them out to the reviewers. Thanks.
Great. Well, I know we're out of time. I want to be respectful of everybody's time here, so we'll go ahead and close out for today. If you do have questions or thoughts or ideas, shoot me an email, shoot our public health team an email, or give us a call. We're always glad to hear from you. And if we don't hear from you until next month, have a great holiday break, and we'll look forward to connecting again in the new year. Thanks so much, everybody.